Hello, everyone. My name is Dr. Rakesh Jain, and it's my pleasure to welcome you to this session titled Long-Acting Injectable Antipsychotics, Practical Considerations and Impact on Adherence in Schizophrenia. This activity has been supported through an independent educational grant from Teva Pharmaceuticals. While I introduce the speakers for this session, if you haven't already done so, please take a moment to answer the polling questions. You should see them on your screen. Depending on the device you're using, the questions will either appear to the right of the live stream or just below. These questions will be asked again at the end of the program. We appreciate you answering the polling questions. It's my pleasure to introduce our two speakers for this session, Dr. Sanjay Rao and Ms. Hannah Phillips. Dr. Rao is an Associate Clinical Professor of Psychiatry and Associate Residency Training Director at the University of California, San Diego, and the Site Director for Residency Training at the VA Medical Center in San Diego, California. Ms. Hannah Phillips is a psychiatric nurse practitioner at Big Bear Behavioral Health in Maitland, Florida. You can type in your questions for the presenters in the Q&A box to the right of your screen, as well as upvote questions submitted by other attendees if you want to see their question answered. We will try to answer all of the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Greetings. My name is Hannah Phillips Hall. I'm a psychiatric mental health nurse practitioner, and I'm getting the opportunity to present today with Dr. Sanjay Rao. Together, we are discussing how we can use long-acting injectable antipsychotics and taking into consideration some of those practical elements and what the impact of adherence is for our patients with schizophrenia. These are our disclosures. So again, disclosure, this is applicable for CME credits. So some of our learning objectives today. We will first outline the role that long-acting injectables, or LAIs, can play in patient preferences. We will then have the opportunity to discern some of the differences amongst the LAIs as it relates to pharmacodynamics, pharmacokinetics, indications, and other nice nuances. And finally, we'll get the chance to integrate this knowledge into a patient case study. So let's dive into Peter. Peter is a 19-year-old college freshman. Peter is the first in his family to attend college. A very ambitious young man would like to become a physician. There is no family history of any type of mental illness whatsoever. In the fall of his first year of college, Peter finds himself slacking with his grades, not meeting the expectations that he knows that he's capable of. He has difficulty concentrating. He becomes preoccupied with thoughts that are maybe beaming into him by way of a satellite, and he often feels like he is part of a chosen few. By winter, Peter has failed a course, received a D in his other course, and he's been placed on probation. By March, he's been arrested at a local supermarket. He ended up destroying a portion of the dairy section and then claimed that the food had been tainted by aliens. Law enforcement was called, and Peter was brought to the local ED for assessment. Peter was subsequently admitted to a locked inpatient unit, and while under the care of the physician and treatment team at that unit, Peter was successfully treated with 3 milligrams of Risperidone. He was offered the opportunity to try a long-acting injectable formulation, but he was deeply reluctant to start that injectable.
So what is the real issue here? Struggles?
I'm not getting those shots. Those docs must think I'm really sick or something, but it's not freaking happening. I don't like pain. I know I'm a grown man, but whatever. I don't like needles. I remember when they forced me down in the ER and it hurt. And they want me to take shots just because I forget my pills sometimes. Come on, man. That makes no sense to me. You know I'll do better next time.
So Hannah, thanks so much for that introduction and for giving us that look into Peter. And thanks everyone for me as well for joining us here. You know, I really like this video for a couple of reasons. I think it illustrates some of the things that are very stereotypical about how our field sees LAIs and how patients see LAIs. So first, you've got this young man who already has this concept of what a long-acting injectable is, right? It's kind of like the thing he got as an acute IM when he was in the ER being held down because he was agitated. And because of that, he's already got this bias against it, and he thinks it's only for people who are super sick, and hey, I take my meds most of the time, I promise, I can do better on this. And so that's really the way we've been trained to think about these things. The other part I think it really brings up is his own admission that he does not take his medications all the time. And this is the part that we're going to start with here in this next section, and that's the challenge of adherence in schizophrenia. And so what do we know about this? Well, we know that it's really common for patients to stop their meds. Depending on what study you look at, within about 6 months of starting meds, maybe about half of our patients will go off of them. Those numbers continue to go up pretty rapidly as your time window goes up. We also know that when people stop meds, this often leads to a relapse, even if it's very early in their treatment course. So let's say you're seeing them for the first time, their first psychotic episode, you diagnose them with schizophrenia, you put them on meds, they stop. Even that gives them a much higher chance of relapsing and having another psychotic episode. And we know that the more often this happens, the longer it takes you to treat them the next time around, the more likely they are to become treatment resistant and to not respond to the thing that you use to treat them. And the more likely they are to decline overall, right? It's their baseline does not stay the same through these repeated episodes. Their baseline gets worse and worse and worse. And so your maximum gain from getting into remission the next time around also goes down the more times you relapse. And although it's not the only answer, we also know that being on medications is really one of the primary keys to stopping this from happening. We know that people who don't take their antipsychotics relapse within a few months. Half of all patients who don't take them will relapse within just a few months of stopping their meds. And we know that this is much better for people who do take them. The relapse rate in adherent patients is much lower than the relapse rate in non-adherent patients. You can see the number needed to treat here of 2, which if you've ever looked at a psychiatric study, you know that an NNT of 2 is huge. That's a very low number of people to treat for a substantial gain. It's gotten to the point where even the APA has figured this out. So if you looked at the APA guidelines up until 2020, they basically said you give long-acting injections to people who are really treatment resistant, who failed multiple meds, who can't take their medications, and so on and so forth. And now finally in 2020, they have this updated guidance which says you should give them LAIs for all those other reasons, yes, but also if they prefer to take an LAI. What I will say about this is if you're really basing this on patient preference, one of the things you'll learn a little bit more about later in this program is you've got to provide good patient education, that you can't truly know whether a patient is going to prefer something unless you've actually educated them on what their choices are and they're making an informed choice on their preference. And so let's look a little bit more at Peter. So in this video, you're going to see he's back at school. He's not taking his meds regularly. He's kind of embarrassed to do this in front of his roommate. And on the same time, he recognizes this could be a problem. Like this might land me back in the inpatient unit and have me fall further behind school.
Hello, Peter. I haven't seen you in about 2 months, and I see you were recently discharged from the hospital. What led you to getting hospitalized? I'm curious to know.
So, it's the same story of my life. I do really good with my pills for a while. I take my pills, go to therapy, the voices go away, and it's all good. But then I start forgetting my pills, and things got real bad this time. So I got sent to the emergency room.
Peter, I understand. I can't tell you that I'm always 100% with my own blood pressure medicine. So I understand. But we know how important your medicine is for you, right? Mm-hmm. How have you been with your pills in the last month?
I swear, I was doing good. Seriously, I was. But the stress of work and school just got too much for me. I started forgetting my pills 2 days in a row. Then it became 3, and I'm not gonna lie, I'm kinda embarrassed taking them in front of my roommate and people I work with. It's just embarrassing. But seriously, I'll take my meds every day this time.
I really appreciate Peter's honesty, but at the same time, I can't help but hear his defensiveness and how he responds to that question of trying to assess for adherence. So let's take a look at some of the impact on treatment outcomes as it relates to our patients on long-acting injectable antipsychotics. So we know that real-world studies favor the use of long-acting antipsychotics. This is based off a randomized controlled trial in addition to other real-world study designs. And they wanted to take a peek to try to establish what bodes best in the real world for our patients as to how it relates to medication adherence. And it was found that the patients on an LAI were far more motivated, more likely to adhere to that medication versus the oral competitor in that real world design study. So we also know that LAIs help to reduce readmission rates. In fact, a study of LAIs when it was compared to oral antipsychotics showed that they were very efficacious in preventing readmission. In fact, LAI treatment was reduced by readmission by approximately 29% compared with the oral medications in the real world setting. LAIs reduced readmission rate by approximately 58% in patients with those repeated admissions. I can't help but wonder always when my patients keep on coming back to the inpatient unit, what's going to be different this time? How are we going to achieve remission with them? And to keep on giving those patients the same oral formulation while expecting them to achieve remission while not getting readmitted seems to be setting them up for failure. So, contrary to what we might see actually being done in clinical practice, LAIs are not intended to be reserved and saved for patients that one would describe as the worst of the worst. In fact, what we're looking at right here is what's known as the Relapse trial, which is the prevention of relapse in schizophrenia. So for patients in this trial, these are patients that are within the first 5 years of their illness. And we can clearly see here that long-acting injectable antipsychotics really help to significantly delay the time to hospitalization and had a positive benefit on both personal and economical outcomes for our patients. Key learning point. LAI antipsychotics may be more useful to patients with repeated admissions in real-world settings compared with daily oral medications, AKA, as I lovingly refer to oral medications, 60 opportunities to forget a month if it's BID dosing or twice daily, or 30 opportunities to forget a month if it's once daily dosing. All right, so some of the potential advantages of LAIs. First, we know if the patient comes in, receives the injection, then guess what? They've taken their medication that will last them whatever length of time that medication is intended to cover. We also know that we achieve stable plasma levels with less of that peak to trough fluctuation, no first pass metabolization, equal or increased efficacy, and sometimes fewer side effects compared to those oral counterparts. I always try to educate my patients that if they're going days and days without taking their oral medication and then they go ahead and take their maximum dosage of that oral antipsychotic, they're going to likely experience some side effects as compared to if we have it in the background at a nice stable level for them. We also know that the lack of adherence can result in symptoms. And so unfortunately, when patients are on oral medications, we're able to see that breakthrough much more readily. But when the patient is on an LAI, we don't see that immediate drop in drug levels. And patients do prefer them if given the opportunity to try them. So some of our options here in the US, we have 2 first-generation antipsychotics, of course, often referred to as the DEC injections, halodecanoate, fluphenazine, or Prolixin decanoate. We know that based on the formulation, it can be given every month, every 2 to 4 weeks. We also have the Risperidone or Paliperidone formulations. We know that we have Risperidone Consta, which is given every 2 weeks, Risperidone subcutaneous, which is given every 4 weeks. We have Paliperidone palmitate, which is every 4 weeks, Paliperidone palmitate as well with larger size, which is every 3 months. And then we have the Aripiprazole formulations. Aripiprazole monohydrate, which is given once every 4 weeks. Aripiprazole Laroxal, which is monthly, every 6 weeks or every 2 months. And then finally, we also have Olanzapine palmitate, which is given every 2 weeks or once monthly, but does require enrollment in a REMS program.
Thanks, Hannah, for that overview. So in addition to the existing options, it's also pretty exciting. We've got a lot of other things coming down the pipeline. So with Risperidone and Paliperidone, there's actually a 2-month version of the subcutaneous LAI that's being studied right now. There's also a Risperidone IM that's monthly and doesn't need any oral supplementation. They are working, Janssen is working on a 6-month Paliperidone palmitate. So if that comes out, you'd only have to give that twice a year. And this is really kind of exciting to me and hopefully a sign of things to come. But there's even a Risperidone extended release oral capsule that you could take once a week that's in the works. And that's something we haven't seen in a long time, an extended release oral medication that only has to be taken once a week. And so I find that pretty exciting. And also on the Aripiprazole side, there's a 2-month version of Aripiprazole monohydrate, which is being studied. So here's some of the data behind some of these new formulations. So to begin with, you've got the subcutaneous 2-month version. That was looked at in a 15-month double-blind randomized trial. And what they found was that both the 1-month and the 2-month subcutaneous versions delayed time to relapse. For the 1-month version, that was a risk reduction of 80%. And for the 2-month version, that was a risk reduction of 62.5%. There's also a phase 3 trial that just got completed for Paliperidone palmitate 6-month. That one also showed that the 6-month version had essentially similar efficacy to the 3-month version in delaying time to relapse. And finally, that 2-month version of Aripiprazole monohydrate is currently in phase 1B, and so we don't have results from that, but of course we're hopeful that that one works out as well. And so key learning point from this, we've got a lot of options in long-acting injectables already, and there's just more on the way. So we're going to have a lot of flexibility, especially with Risperidone, Paliperidone, and Aripiprazole, of exactly which product we choose and what the dosing duration is and what might best suit the patient that we want to give this medication to. All right, so in this next section, we're going to really dig into the meat of these individual LAIs, talk about the specifics of each of these options that are available and how you might go about choosing between them. And so before we do that, I think it's really helpful to have a bird's eye view of what an LAI is and kind of how it works and why does it work and how does it compare to the medications that we can take orally. Because I think although many of us understand this to a certain extent, there are also some misconceptions about things like half-life and so forth. And so we'll kind of go through that right now. So to start with, oral drugs, really simple, right? These are all water-soluble compounds. You swallow them, they enter your GI tract. Because they're water-soluble, they quickly go across that membrane, they absorb into plasma, you have active drug, and there you go. And how quickly your drug leaves your system, well, that just depends on how quickly your liver can get rid of it or how quickly your kidney can get rid of it. So essentially metabolism and excretion, and the amount of time it takes for half your drug to get out of there is what we call the half-life, right? And so that's really simple and straightforward. With LAIs, we have to turn this paradigm on its head a little bit. Because if you take a bunch of water-soluble drug and you put it in someone's muscle or subcutaneous tissue, well, guess what? You're going to get all of that drug entering their plasma right away, and you really don't want that, right? You need something that absorbs over time. So how do you do this? Well, the details are different for each drug, but the basic idea is you take this water-soluble drug and you somehow make it fat-soluble. That might mean you attach a long-chain fatty acid to it, right? Essentially, you esterify it. Or that might mean you encase it in something that's really fatty. But the bottom line is you're taking it from being water soluble and turning it into being fat soluble so that when you stick it in someone's muscle, right, when you put a 30-day supply of this medication, essentially the entire pill bottle, right, in someone's muscle, it's not going to leave that muscle right away. Because it's fat soluble, it's going to very slowly absorb into plasma. And then once it gets into your plasma, you've got all these enzymes swimming around in your plasma. They cleave off whatever fatty modification you made for the drug. And now you've got your active drug, and it's the same active drug that you had when you took it orally. So whether you take Risperidone orally or Aripiprazole orally or get them in an LAI form, you're getting the same active drug. It's just that the delivery system delays this absorption and delays this release for a while. So let's now do kind of an overview of the different available options. And let's start with the, let's be honest, the stuff we use most commonly, which is the Risperidone, Paliperidone compounds. And of course, we're putting these together because Paliperidone is really just the active metabolite of Risperidone, right? You take Risperidone, it goes through your liver metabolizes it into 9-hydroxyrisperidone, which is paliperidone. And so these two drugs are very related. And for anybody taking risperidone, most of what's in your bloodstream is actually paliperidone. More than half of it is actually paliperidone, even if you're taking risperidone. So they're functionally very, very similar to each other. So what are our options here? Well, right now on the market, you've got paliperidone palmitate monthly. And the way you initiate this is you give them 2 injections 1 week apart right at the beginning. That brings up their drug levels. And then after that, you do monthly maintenance doses. And then if you've been on paliperidone palmitate monthly and you've been stable on it for at least 4 months, you have the option of moving to this 3-month version, which now instead of the 1 month injection, you give the 3 month, and then you give them every 3 months after that. The reason you got to do the 1 month first is that the 1 month is essentially your initiation regimen for the 3 month. You have to get the drug levels up into a steady state with the 1 month so that you can handle the little bit of a drop that you get right at the beginning with the 3 month. And then on the risperidone side, of course, we have the original risperidone microspheres, risperidone consta. That one, you've got to dose it every 2 weeks. And it takes a while to absorb. So you actually have to give them oral risperidone for at least 4 weeks right at the beginning. And then you have the newer version of risperidone, which is the subcutaneous injection. This one you dose monthly, and this is one of the ones where you don't need any initiation regimen. The reason for that, it's actually a really neat formulation. It's encased in this, essentially this gel matrix. And so when you put it subcutaneous, some of the risperidone enters your plasma right away. And you can see that on this where you look at that first peak of 4 to 6 hours. And that's your initiation. It's that risperidone entering the plasma right away. And then the rest of it actually solidifies in this gel matrix and essentially becomes a biodegradable implant. And that one takes a lot longer to release, and that's kind of your maintenance. And so they found a way to kind of engineer this to be both its own initiation and its maintenance with just that one injection by having these 2 different mechanisms of absorption right at the beginning. If you're wondering, well, how do you decide how much of this stuff to give as a maintenance dose, beyond the initiation? You can kind of consult a table like this, which shows you the oral equivalents. And so as an example, if your patient is on 4 milligrams of risperidone a day, or you think that that's what they're going to need, this shows you the doses for the 1 month paliperidone palmitate, the 3 month paliperidone palmitate, the subcutaneous risperidone, and the microspheres. And so it's pretty straightforward. These doses of the LAIs will give you roughly equivalent plasma levels to the oral dose that's on this table. So now let's take a look at aripiprazole, and you've got 2 choices currently. You've got aripiprazole monohydrate, which was the first one to come out, that was the Maintenna, and then you've got aripiprazole Laroxyl, which is the more recent one, Aristada. So with the monohydrate, it's very straightforward. It's just once a month dosing or once every 4 weeks dosing. And you've got to give 2 weeks of oral aripiprazole at the beginning until you build up drug levels from the monohydrate injection. With the Laroxyl, you've actually got multiple doses and multiple dosing intervals. So there are doses for every 4 weeks, every 6 weeks, and even every 8 weeks. And when this first came out, you also had to give oral overlap in the beginning. You had to do 3 weeks of oral overlap. But in the last couple of years, they've come out with this second injection that's based on a nanocrystal formulation, different from the original maintenance injection. And the goal of the second injection is, instead of giving them that 3 weeks of oral overlap, you actually can just give them this second injection right at the beginning, and that takes the place of the 3 weeks of oral overlap. So you can initiate them in 1 day just by giving both these injections at once, the traditional Laroxyl injection and the new nanocrystal Initio injection. Here's an idea of the dosing equivalents of each of these things. So with the aripiprazole monohydrate, it's a little deceiving here because really the guidance from the company is just start them at 400 milligrams and just keep them at 400 milligrams unless they can't tolerate it, in which case you go down a bit. Whereas for the Laroxal formulation, you kind of do the same thing that we did with Risperidone, where you think about how much aripiprazole does this patient need and what's the equivalent dose to get there. I'll just highlight the 8-week dose, which is kind of neat because you can start with the 8-week dose and then now right off the bat you have every 2 month dosing in your patient. So why would you use this relative to paliperidone? Well, you're using aripiprazole instead of paliperidone, so you're getting that. And so what does that mean? Well, it means that your long-term metabolic risk and risk for weight gain is probably a bit lower. It means that you're not going to, in general, have any prolactin elevation. And if you're using the one that has the 8-week formulation, you've got a pretty big missed dose window. So even if they're 2-3 weeks late, you can often make that up just by giving them their next injection. So now what's the downside to this? Well, you're using aripiprazole and not paliperidone. And there are some patients who need full antagonist activity, like what you get with paliperidone or risperidone, to get an optimal response for their schizophrenia. And so if you're that kind of a patient, it's probably not going to work for you. And then the other thing, and this is the part I kind of want to emphasize, before you load up someone on an aripiprazole LAI, I really encourage you to make sure that aripiprazole is actually working for them. And the reason for this is that aripiprazole and the other partial agonist molecules have really high D2 binding affinity. Essentially, they bind the D2 receptor an order of magnitude more strongly than haloperidol or risperidone. And so the upshot of that is, if you prematurely give them an aripiprazole LAI, and then a week down the line you figure out, oh, aripiprazole is not actually working for them, you're going to have to work really hard to override that because their receptors are now very tightly bound for the next several weeks with this aripiprazole LAI. And so personally, what I do is I have someone on aripiprazole oral, and I make sure I'm getting some reasonable response with aripiprazole oral before I transition them over to aripiprazole LAI. You know, and of course, we cannot forget about Olanzapine LAI. And sadly, because of the REMS, this often gets forgotten about because it's a little bit harder to use. But the reality is that many of our patients do need Olanzapine. And so if you need Olanzapine and you're struggling with taking Olanzapine, then the Olanzapine LAI is your only option. And so we should be familiar with how to do it. So this is Olanzapine palmoate. It's available in a variety of doses with a bunch of different dosing equivalencies and either 2-week or 4-week intervals. And the basic idea here is that up to 15 milligrams a day you can cover with 4-week dosing. But if your patient needs 20 or more milligrams a day, the injection volumes for that are too high, and so you've got to give that every 2 weeks. Not as convenient as 4 weeks, absolutely, and also not as convenient as other LAIs, because you do have a REMS warning here. And that warning is based on the fact that a small number of patients in the clinical trials had a fairly significant amount of confusion and sedation, and some had to be admitted to the hospital. And this was not just after the early injections, but could happen at any point down the line. It's probably a dumping syndrome where too much olanzapine enters their bloodstream because it wasn't injected exactly the right way. And so because of that, after every injection, they've got to be watched for 3 hours. This obviously makes it more burdensome on the clinic and so forth, and so this tends to not be used as much, but I really would advocate keeping it in mind for patients who require olanzapine, if that's the thing that really works for them. So how well does all this stuff really work, and how good are these medications compared to each other? So first thing you can look at is you can look at all the placebo-controlled registration trials across all the different indications. And the bottom line here is that they all appear to have roughly the same effectiveness. Their number needed to treats are pretty similar across the board, and their rate of efficacy compared to placebo is pretty similar across the board. Again, you can't compare these studies directly because they're all different studies with different patient populations. That's kind of reassuring that regardless of the indication and regardless of the drug, you're getting a relatively consistent effect. And then a number of these medications have also been studied not just against placebo, but also head-to-head against other medications. So for example, aripiprazole Laroxal did not a head-to-head, but essentially an active control study against paliperidone palmitate, where they had 2 individual tracks of patients, and paliperidone palmitate was being used as an active comparator. And they found that both these medications were efficacious, well tolerated for treating acute exacerbation of schizophrenia, and then also continuing on as an outpatient. And then paliperidone palmitate was actually tried head-to-head against oral antipsychotics, looking at time to treatment failure, and demonstrated fairly convincingly in a really complicated patient population. So people who were people who'd previously been incarcerated, and some of whom were homeless and using substances, demonstrated superiority to oral antipsychotics, both in time to treatment failure and also delaying hospitalization and or reincarceration. And then finally, aripiprazole monohydrate has a couple of studies comparing it to paliperidone palmitate in psychotic disorders. And what they found in those studies is similar efficacy to paliperidone palmitate, and perhaps improvements in tolerability for sure, and also quality of life. And so a really rich and I think interesting data set, both in the original registration trials versus placebo, and also with some trials against another active drug. And so what's the takeaway from this? We've got a lot of different LAI formulations. There are differences between them, and you want to take your time to think through which particular drug might be most advantageous to a patient. And so what are some of the things you think about if you're trying to differentiate between all of these? Well, you want to think about the dosing interval. You want to think about how painful is this going to be to go in. And here I've got some good news for you, which is that all of the 2nd generation LAIs are all injected in a water-based medium. So you use a relatively smaller gauge, shorter needle that's less painful. The older LAIs, haloperidol and fluphenazine, are oil-based. And so those use larger needles. And so if someone complains of injection pain with one of those older injections, that doesn't necessarily mean they can't tolerate an LAI from a newer injection. You'd also think about, can you give this in the deltoid, or does it have to be given in the glute? And does the patient really have a preference? How easy is this thing to deal with? Do you have to refrigerate it? Do you have to reconstitute it, or is it kind of ready to go? Good rule of thumb, anything based on risperidone needs refrigeration. And then you consider drug-drug interactions. Are they on particular medications that might interact with this particular one? And how is this medication actually metabolize? And then if you're worried that patients are going to have a hard time coming in, what's the grace period, right? So how long can they go having missed a dose, and then you can still just give them their regular dose and keep going. Here's kind of a quick and dirty way of thinking this through. It doesn't cover everything we just talked about, but I find it to be a useful starting point. So my first rule, if the patient is well controlled on an oral medication and they're tolerating it, and that medication has an LAI, you really should think about using that particular LAI. So if your patient is controlled on risperidone, then please think about a risperidone or paliperidone LAI. If they're controlled on aripiprazole, please think about an aripiprazole LAI. That is your best bet because you already know the molecule works, and you are, after all, just delivering the same molecule with a different delivery system. Now, what about if you're worried about whether they'll follow through with oral supplementation? Well, then pick something that doesn't require oral supplementation. Think about paliperidone palmitate, or aripiprazole Loroxol, or a sub-Q risperidone, or even Olanzapine palmoate. Are you worried they're going to gain weight, or have prolactin elevation? Well, if you're worried about them gaining weight, well, you probably want to think more along the lines of aripiprazole, and at the very least, you should probably not be thinking about Olanzapine unless that's absolutely necessary. And for prolactin elevation, again, you want to think more in the direction of aripiprazole, and you probably want to avoid high-potency D2 antagonists like risperidone and paliperidone. Now, on the other hand, let's say you've maxed out risperidone or paliperidone. They're getting better, but they still need more drug. Well, this is where you may need to consider a first-generation LAI like paliperidone, because you can push the dose to get higher D2 antagonism than you can even with a maximum dose of paliperidone.
So, while we just had the opportunity to get through all the nuances of the various options we have, the bigger question remains, how do we get patients to agree to this treatment? So it's important to first identify if the patient is unwilling to adhere to the medication or if the patient cannot adhere, potentially due to some cognitive limitations, maybe environmental difficulties. If the patient is unwilling to adhere, we should probably focus on the intervention that aims to strengthen the benefits of being on medication compared to the perceived negative benefits, which personally I tend to have patients that struggle with the social outcomes, the negative legal outcomes, and by identifying some of those basically psychosocial issues, I'm able to use tangible examples as to where things may not have gone the way they would like them to potentially go. We also know that motivational interviewing is a therapeutic communication technique that can be efficacious at helping to move a patient along those stages of change. However, if the patient cannot adhere to treatment, it's important that we try to focus on some of those behavioral interventions, such as routines, self-monitoring tools, and it's really important that we engage with their caregivers. So communication style is critical, of course. Again, motivational interviewing aims to explore the ambivalence that might surround the patient making this change. As was previously described, it's very unfortunate when our patients blend the idea of what we're offering them of an LAI compared to an emergency treatment order or something they may have previously experienced that could be traumatic. And maybe even if they themselves didn't experience that, perhaps they witnessed somebody else on an inpatient unit who had in fact experienced that. So hopefully through motivational interviewing, we are able to use those open-ended questions, reflective listening, and keep on touching back to those patient goals that they have created for themselves, while still tying in that emotion to the goal and where there might be a bit of a barrier there. So there's a thing to remember called RULE. RULE represents resisting the urge to make too many suggestions. I fall victim to this probably more often than I'd like when I do verbal diarrhea or verbal excitement of all the things that I want to encourage the patient to maybe do differently. But hopefully by focusing on one thing, one intervention, one measurable outcome, you are then able to make that more achievable for the patient. We also need to understand what their motivation is. I've had patients before who openly say that once they got on antipsychotic treatment, they kind of missed the voices that they had previously experienced. So that might be a difficult patient to try to motivate into antipsychotic treatment. But these patients also had negative legal outcomes. So in the cases that I'm potentially tapping into there, those were the outcomes that I used to try to help to motivate the patient along that area of change compared to the symptom itself. What is the outcome that the patient is wanting to avoid? It's also important that we listen with an empathic and patient-centered approach as previously described, and then empowering the patient. What do you want to make from your future? Quit living in reaction to being hospitalized, incarcerated. Let's start making these intentional changes, intentional goals. So, the entire treatment team has a role to play in how we aim to achieve acceptance of LAIs amongst our patients. Number one, it's important that we use continuity of practitioners as well as leaning on the benefits of that therapeutic relationship. So hopefully by including members of the treatment team with whom the patient has a good relationship, we are able to benefit from that when we're exploring this idea. It's important that we discuss this early in treatment and that we're not just reserving this for patients who are in their second or third decade of illness. It's critical that we don't just let them know about it once and then never go back to the subject. It always amazes me how many of my patients go from a hard no to a potential consideration or even a yes of an LAI without me even understanding fully what's changed in the background of their life. It could be something interpersonal, occupational, educational, but do not just set it and forget it. So it's important that we understand the patient's perception of what those advantages are for themselves compared to the specifics of the symptoms. It's important that we utilize active and reflective listening. We convey empathy. We are able to communicate to patients that we totally aren't blaming them for that challenge of adherence, but rather, what can I do to help you with it? Because it's something we universally struggle with regardless of disease state. It's important that we also try to refrain from making unsolicited suggestions, and that at the end of the day, we continue to work with the patient when trying to educate them about the chronicity of their illness, as well as the ways that they can change that. Unfortunately, they can't change the cards they've been dealt, but hopefully by working more effectively with that arena, we are able to get them to consider what possibilities might exist that they had previously eliminated after diagnosis. Peer specialists are great in helping our patients who are really struggling in that arena as it relates to how they feel about this diagnosis, in addition to the idea that this could be a useful treatment modality for themselves. And it's also really important that we continue to educate about proper administration techniques. Hopefully, in doing this, we are able to minimize the perceived experience of pain amongst patients. And we know that by having staff members that are confident in what they're doing, we are hopefully gaining confidence from the patient as well. So let's go back to Peter. So Peter's doctor offered him the option to take a medication only once a month, or how would you feel about once every 3 months instead of every day? I mean, I'm looking at those numbers there, and I don't see why Peter would choose against that. Peter, however, is reluctant to take a medication that would be administered by the physician, but considering Peter's background of paranoia, distrust towards the powers that be, this kind of facilitates some of the symptoms that we see further with his illness.
Peter, I know your heart is in the right place. I know you want to do good in life, hold down a job, and finish school. But we've got to be honest here. It's been very difficult for you to remember to take your medication regularly, right? I'm not passing any judgment on you.
I'm being real with you. I just keep forgetting. That's just the truth. I just keep forgetting, and I don't want to ask my family or roommate to remind me because I'm scared they're going to think I'm a crazy person. But I told you, I'm going to be better this time. You got to give me another chance.
Peter, I know your heart is in the right place, but you know I am on your side and want the best for you, right? We have talked about other treatment options before. How would you like taking your medicines once a month instead of every day? Can you help me understand why you are worried about these injections?
I'm afraid they're going to hurt a lot.
It is an injection, kind of like a flu shot. I wish there was one I can take instead of remembering to take my blood pressure medications every day. Let me tell you why these long-acting injections may be a good idea for you to consider. For one thing, they are way more convenient for you. And I'll top that off. You won't have to struggle to remember to take the medication every day. And you won't have to be embarrassed by asking your family or roommate to remind you. It's not like that shot you got in the emergency room. This is completely voluntary. If you don't want the second shot, we can go back to pills. How do all these things sound to you?
If it will really make things easier for me, I'll give it a try.
Good. I won't be recommending these long-acting injections unless I really believed in them. Let me tell you more, and I promise you, I will answer each and every question you have.
Hey, well, that's a really nice turnaround for Peter. And you may be watching that and thinking, does that actually really happen? So, do you actually have patients who are super reluctant to take medications and are kind of defensive all the way through? And then just by the way you present it to them, you can change their mind and move them forward. Well, this has actually been looked at. And so here's an example of it. The study you've seen on the screen here was essentially a study looking at communication patterns between psychiatrists and their patients at a bunch of different community mental health clinics. And so what did they find? Well, in the beginning, what they found was that only a small number of psychiatrists even actually offer LAIs to their patients. And when they offer it to them, they often offer it in a way that's very kind of neutral or wishy-washy or kind of negative. And when the patient initially says no, because if you offer it that way, they're probably going to say no, then they just kind of abandon it and don't offer it to them again. And so, surprise, surprise, when you look at the standard approach that's used in many places, not that many patients actually accept LAIs. However, they went back to these patients. They did post-visit interviews and talked to these same patients again. And this time they gave them information about LAIs in a much more positive light with more information and a much more balanced approach, really kind of keying into informing them what this is all about and highlighting not just the downsides, but also the benefits of these treatments. And when it was presented in this way, most of the patients that had previously said no actually reversed their decision and said, oh yeah, no, that sounds reasonable. I would try that. And so I think, it's really to me a stunning example of how the way you communicate this information to your patient really matters and really makes a difference in whether or not they're actually going to choose an LAI. So we're at the end here. Let's kind of wrap this up. What have we looked at in this program and kind of what have we learned? Well, we've talked about schizophrenia relapses being really common, resulting in poorer functioning over time and a worse illness over time, potentially treatment resistance over time, that much of this is due to medication adherence being really challenging for our patients with schizophrenia. We've presented data on LAIs positively impacting treatment outcomes, and crucially, that if you present this in the right way, patients will often prefer an LAI. But you need to offer this to them as a choice, and you need to present it to them in a way that fairly represents what the LAI is actually about. And we've talked about how choosing the right LAI is really a collaborative partnership. You need to think through what's actually going to work for the patient, what delivery system is going to work for the patient, what kinds of other things might be stumbling blocks, and really engage in that collaborative relationship with the patient to figure out what's going to work best for them. And finally, as we just saw, if you really want to convince your patient to do this, you have to believe it yourself, right? You have to present it in a fair and positive light, and you have to not be discouraged with the first no, right? People change their minds. If they didn't change their minds, then what are we all doing in business? And so you have to accept that you can change your patient's mind over time. You've just got to persist a little bit longer and give them the information that they need to do that.
Welcome back, everybody. And before we jump into Q&A, please be sure to answer the post-activity questions to the right side of your screen. Please click the Submit button after the last question to successfully submit your answers. And as always, thank you so much for answering the polling questions. And thank you, both of you, so much for such an excellent presentation. As I shared with you before, I'll be asking my residents and fellows to watch it. Our audiences do have some questions for you, and because we have limited time, we're going to focus just on one question. I'll start with you, Sanjay, if I may. If patients are on the highest dose of a particular LAI but still have breakthrough symptoms, do you recommend oral adjunct antipsychotics or earlier injections? What is your approach?
So this is a great question, and I think it illustrates both the benefits and some of the limitations of the LAIs we have. Because if they're having a partial response to an LAI, but they're still having breakthrough symptoms either near the end of the injection cycle or perhaps even throughout, it probably suggests that their plasma levels are insufficient. They're just not getting enough of a dose. And our LAIs max out at reasonable, but not the highest possible doses. So our Risperidone LAIs max out around 6 milligrams of Risperidone a day. Aripiprazole LAIs max out around 20 to 25. And you know that with oral, you can go higher. And so depending on when they're breaking through and when you're seeing those symptoms, and if they've had a partial response, the answer is to get their plasma levels higher. And there's a lot of ways you can do that. You can do that with more oral. You can do that with more frequent dosing. Or I think Hannah's going to tell you about a way that might be a little more innovative than that.
Hannah, tell us about this innovative way.
Well, thank you. I was going to say, number one, if you're able to finagle with an insurance company, being able to dose early kudos to you. However, I sometimes look at making sure that there's not an issue of user error going into this therapeutic failure, perhaps. For instance, is this a medication that could be potentially not getting reconstituted properly? Or is this a medication that might need to get more shaken more adequately or given in a different muscle site? To pick on a specific example, if I could, being mindful about the half-life differences between deltoid administration compared to gluteal administration is significant for some products. For instance, with Invega Trinza, we know we have a half-life with the 819 milligram dosage of 95 days in the deltoid, but it's 139 days in the gluteal site. So that's significant if I'm having a patient with some breakthrough symptomology. However, I do know a lot of patients tend to prefer the deltoid site of administration for discretion reasons, but it's worth pursuing, finding out if maybe switching sites could be beneficial.
So it sounds like there's a lot of different ways to get to Rome. But the thing is, you got to get to Rome. You don't want to leave a patient partially responsive, especially if other opportunities are available. Thank you both for those wonderful insights. And unfortunately, we are now out of time. Next time, hopefully, we'll have more time. So thank you again. And to see what sessions are coming up next, please, everyone, all the attendees, please visit the live agenda page on the website. Thank you for attending this session. I hope you enjoyed the rest of the conference. Bye for now.
Thank you. Take care.